Hi, my name is Ruff. Before we get started on this presentation, I want to introduce my interprofessional healthcare capstone project, Finding Value in Cancer Treatment Costs. This topic of choice came naturally as I have had and currently have loved ones affected by cancer. I felt it was important to examine this topic closer because cancer has touched so many lives. I hope you enjoy this discussion on how I plan to improve cancer care and help patients manage the costs that come with it. In 2015, America spent $3.2 trillion on national health care. That is almost $10,000 per person. Managing diseases like diabetes, heart disease, or cancer takes up about 90% of that $3.2 trillion dollars. The CDC lists cancer as the second leading cause of death in the United States. One out of every four deaths is cancer related, which is troubling because many cancer drugs are now priced over $100,000. $100,000 is pretty expensive, especially when it comes to individuals who are not financially stable and potentially insured by Medicaid. Unfortunately, for Medicaid patients, there is no limit to how much money they will have to pay for treatment. Considering the average annual income for Medicaid patients is around $25,000, how will they afford to get treatment? The trouble patients encounter in affording their treatments is what inspired my change plan. If I wanted to create change in cancer care, my goals would be for patients to experience great care that is strongly evidence based. In addition, it is crucial that patients are more informed and even more involved in every part of their treatment, especially in the beginning stages. Despite patients feeling like they should spend as much as they can to live longer, I want patients to be aware of less expensive options that will still benefit them. Upon searching ways to help cancer patients get more value out of their treatments, I found a health policy article which looks at why cancer drug prices have increased so much. First, cancer drug prices follow their own rules. Free markets are unable to settle down prices due to prominent pharmaceutical companies discouraging competition from generic drug companies. Second, even though other countries like Canada or Mexico don't pay nearly as much for cancer drugs, patients cannot purchase prescription medicines from other countries. It's forbidden by law to ensure patient safety. Third, 40 to 80 billion dollars a year could be saved if Medicare could negotiate prices. But in 2003, the Medicare Reform Act was passed, blocking Medicare from negotiating prices. Lastly, the Patient Centered Outcomes Research Institute, PCORI, that evaluates treatments for federal programs is not allowed to consider cost comparisons and cost effectiveness to the government. There is a significant need to not only lower the number of people affected by cancer, but also lower the cost they experience. Partly because patients who are misguided by their physician on the severity of their diagnosis will seek treatment even though it won't benefit them. On top of that, patients who are uninformed are also not aware of the effects expensive cancer treatment will have on their day-to-day lives. Studies show that patients will go to extremes like skipping meals or doctor's appointments to save money. If patients are having financial problems during treatment, chances are they will either not fill their prescriptions, only fill part of it, take less than prescribed, or skip taking their medication altogether. Cancer patients across the world don't have it any easier. In low income countries, medical centers don't have the resources they need to actually treat patients. Despite having an abundance of resources in the US, pharmaceutical companies would rather charge thousands of dollars to patients for a new drug that is only a molecule different from an old one than develop cancer drugs with greater value to patients. Value, when it comes to cancer treatment, is extremely important. What use is a treatment if it does not help a patient live a healthier and longer life? The American Society of Clinical Oncology developed a value framework for cancer drugs by comparing treatments that have been previously studied in clinical trials. This framework calls for physicians and patients to have meaningful conversation about chances of survival, treatment options, the value of those treatments, and the financial burden they might bring. The ASCO is firm on the notion that oncologists have a duty to each patient, which is being honest about their patients' health outcomes and willing to give them any and all information they can about their treatment. The value framework takes a look at efficacy, safety, and efficiency in order to assess value. After a net health benefit is calculated, physician and patient can determine what treatment will pose the most value at the lowest cost. The National Cancer Policy Forum published a book on better ways to deliver cancer care. One idea is making good use out of palliative care. Palliative care for patients who received it reduced their end-of-life expenses by 33% compared to those that didn't, easing some financial burden on their families. Also, those who used palliative care had fewer hospitalizations and emergency room visits, which can add up over time. Another idea is improving electronic medical record functioning. EMRs, electronic medical records, can prevent duplicated testing and services for cancer patients. They can also make cancer screening more cost-effective by tracking and helping to manage patients so they receive the right care at the right time. However, the trouble with EMRs is that they don't always give the right data or work well with other software. Medical homes, or in this case, an oncology home, would allow oncologists to provide greater support, oversee more of their patients' care decisions, and give them a better chance to increase their patients' health outcomes. Information from both the ASCO and National Cancer Policy Forum helped me to decide what I'd like to include in my change plan. My place of interest happens to be the only comprehensive cancer treatment center in South Carolina, better known as the Cancer Center at South Carolina Oncology Associates. I'd like to implement the ASCO framework and see if I can help patients find more value in their treatment. Stakeholders at SCOA will be interested in how the value framework fulfills their mission to reducing stress and increasing comfort for patients. I'd hope after I implement this change plan that they will see it brings new value to the extensive care they already provide. In order to get physicians and patients on board, first I want to try out giving physicians a patient care fee. Physicians will receive a payment when costs of treatment are reduced and patients show good results. This can be reducing costs in a number of ways, like reducing relapse rates, drug costs, hospitalizations, or even emergency visits. Patients will receive incentives like free food, clothing, books, and maybe movies for showing up to each appointment on time and filling their prescriptions on time. Within the Oncology Center, physicians will attend classes on how to apply the value framework, and at first, each oncologist will use the framework for 2 to 5 of their patients. The framework software will be downloaded and available from a computer, laptop, or phone, and accessible from any department at SCOA. There will be a fundraising effort by the SCOA Cares Foundation for this educational purpose, just to help provide incentive gifts for the patients during this implementation process. The ASCO framework software should be easy to implement because the Cancer Care Center has plenty of comprehensive and up-to-date technology for use. During this change process, I want to meet with physicians to get their feedback. I'm looking for improvement in patient and physician relationships, plus any changes in the kind of treatment physicians are prescribing. A big part of the success of this change plan is based on patient outcomes and perspectives. Patients will be given small quizzes and surveys before, during, and after implementing the change plan to get a feel for their thoughts on their diagnosis, physicians, and treatment at SCOA. I'd also like to see how well the patient information moves across with the framework in different departments. If patient information is easily accessible, valid, and efficient, the framework will have continued success. Meeting with SCOA's pharmacy department will be the determining factor to see if information provided by the framework has influenced either the cost of treatment or type of drug prescribed. This presentation has been eye-opening for me. Learning about the different aspects of cancer care has given me a new outlook on our healthcare system as a whole. Nonetheless, when it comes to cancer treatment, there is a lot of work left to do. Cancer patients, the people who love them, and the people who care for them each have a hand in changing this issue. I appreciate having your time to share my thoughts with you. Thank you so much.